So let me introduce a little bit. Pardon. You want me to go ahead? So, Dr. Bellier, you have to help me with the French pronunciation.
Yes, Bellier-Teichmann.
Bellier-Teichmann. She will cover a very interesting topic regarding assessing patients' perceived difficulties and needs for care.
Yes.
And she will give us a wonderful presentation, and really looking forward to the questions that follow and the discussion. Thank you very much.
Thank you for this introduction. Hello, everybody. So I'm coming from Switzerland, so Lausanne more specifically. You can see a picture of my city here. And I'm also a psychotherapist, and I will tell you something about the assessment of patients' difficulties and needs. So, first I have to tell you that I did my presentation on a Mac computer, so it's all a bit weird, but sorry about this. So, the general context of this study is the psychosocial investigation of patients. So, for chronic psychiatric patients, usually we see that they suffer from very different kinds of symptoms or various profiles of diagnosis. Therefore, there is a necessity to develop adapted treatments and to define clinical objectives which are also adapted to this kind of chronic patients. And in this context, the assessment of patients' difficulties and patients' needs is a central part. So in this context, we developed a new scale which is widely used in French-speaking countries and also in Canada. So in French, it's called LADEB. In English, it would be DNST, so Difficulties and Needs Self-Assessment Tool. The specificities of this tool is that we are actually using a visual mediation. So as you can see it here, we have cards. Sorry, like this. We have cards that are picturing 18 life domains. So we have different life domains, like, for example, finances, work, physical health, mental health, using public transportation, so everyday life domains also. And we use a Q-sort method. We wanted to do something different from the traditional questionnaires, which sometimes are not adapted to chronic patients who have maybe cognitive or sometimes verbal impairments, or sometimes just don't speak the same language than the clinicians would do. So we are using a Q-sort method. This means that we give the different cards to the patients, and he has to sort them out and to rank them in order to rate the difficulties and the needs he has. So this instrument is divided in two subscales. First, we evaluate the difficulties and then the needs. And then we get a profile of the present problems and requests for help the patient has. The items are scored from 0. This would mean that the patient has no problem, no need, to 3, which would be a very important problem or a very urgent need. And then we also have a qualitative part. This means that we take the time to explore each domain or each maybe important problem with the patient to see how we can help him, who would help him, and so on. So here you can see the different domains we evaluate. So as you can see, we have 4 categories, 4 main categories. So the first one is related to general life conditions. Then we have the everyday life domains, the social network, and finally the health category. So how do we administer the tool? So here I give you a quick example of a patient I met. So we give him the card, and for each domain he will say, okay, for example, administrative tasks, this is a big problem for me, I can't deal with this. Or housework is also a problem. Using public transportation, this is fine. And so on. Friends and acquaintances, this was a problem for this patient. He said, oh, since I have all my symptoms, since I got my depression, all my friends left, so I'm feeling very lonely. Family was also a problem. Children, sentimental relationships was fine, and so on. And then we keep the difficulties, so the cards which are a problem for the patient, and then we will rate the intensity. So either it's a slight problem, a serious problem, or a very serious problem for the patient. And this will help us, of course, to define the priorities for this patient and the clinical objectives or the treatment objectives. Then, of course, we also have always an open discussion with the patient where we really check for each domain. And then, of course, we do exactly the same, or almost the same, with the needs assessment, where we ask the patient which domains he has needs and how urgent these needs are. Are these needs very urgent? This means that he would need help maybe in the next week. Or is it less urgent, so maybe in the next month we can handle this and it's still fine. So the objectives for this current study were the following. We wanted to investigate the factual structure. This means more simply that we wanted to know are there some patients who have specific kinds of difficulties, for example, patients who have only relational problems, or maybe some other patients have more everyday life issues. So we tested this with patients coming from 3 different mental health centers, and we used a new statistical method, which is BGO-mean, but I won't go into these details, I think. So we used the DNST to assess patients' difficulties and needs. And we had 471 profiles of psychiatric patients. And so these are the results. So what was interesting was that we got a general factor of difficulties. What does it mean? It means that patients who tended to have high difficulties or important difficulties in some domains tended to have also important difficulties in all the other domains. And the opposite is true, of course. The patients who had slight difficulties in some things also had slight difficulties in all the others. But we still had some specific factors. So the first one is finances and administrative tasks. So this would be patients having something like maybe management difficulties, which would be the most important in their life. The second factor is related to transports and public places. So we thought about maybe social anxiety, patients who are scared of taking public transports or going to public places. And the third specific factor is really more related to relationships, as it includes family and children. So these are the results for the needs for care. As you can see, they are quite similar. We also have a general needs factor, which would mean the same. Patients who have urgent needs in some domains tended to also have urgent needs in all the other domains. Then also a first factor, which would be something related to management needs. The second factor is a bit different, as it includes housework, transports, public places, and self-care. So we related it to functional disability, so needs related to everyday life aspects, but also self-care. And the last factor is very clear this time, as it includes friendships, family, children, and sentimental relationships. So these are really the patients who have relational needs. or who maybe feel lonely or who have trouble dealing with these relational issues. So this would be the synthesis of the results. As you can see, and as I just told, they are very similar for difficulties and needs, but there are still some differences, and there is always this general factor. So this brings me to the clinical implications. So what we can say on a maybe more general level or public mental health level, the general factor showed us patients expressing either serious or slight difficulties or needs in everyday life domains. So this could be something like an indicator of crisis for the patient. Or we also noticed that maybe some patients tended to express a high level of needs or level of difficulties, but no, the opposite, sorry. Some patients may have a similar level or high level of symptoms, but maybe not seek intervention services as often. So this general factor can also relate to high versus low users of public mental health care, independently of the real level of symptoms they would have. And on a more individual level, what we can say is that the specific factors we found were interestingly related to social interventions, as we had finances, functional disability, interpersonal relationships. These domains are maybe less covered by classical psychiatric or psychotherapeutic interventions, and they may be more covered by something like rehabilitative or community interventions. So for these chronic psychiatric patients, for example, competencies training or financial help or help for social integration. And one last interesting point, I think, was to notice that the three main areas of specific difficulties and needs are very similar to the four types of social support we always found in the literature, which are financial support, which is related to our finances factor. Then we have instrumental support, which is very similar to our functional disability. And the last one, emotional and self-esteem, would be really very close to this interpersonal relationship factor we found. So thank you for your attention. And
okay, this is a good opportunity for questions. Anybody has a question that would like to ask the research? Okay. Would you like to say a little bit? I mean, it would be good if we have your instead of having this. Can we go back? Yes. All right. Sorry. We can. You give us some more details regarding your patients, the specific age group and population of the age group you were assessing, the patients, and the specific difficulties and needs that came up.
Yeah, sure. So our patients were adult patients. They were between 18 and 65 years old.
Okay.
And the diagnoses were the main diagnosis from the DSM-4. So we had schizophrenic, we had mood disorders, anxiety disorders, and personality disorders. This was the main diagnosis from our sample. Oh, I maybe even have a slide about this, actually.
And all of them were in Switzerland?
And it was all in Switzerland with 3 different mental health centers.
Okay.
I'm just checking.
Okay,
yes,
here.
That's the diagnosis.
You had neurotic also and anxiety
Yes.
disorder, right?
Yes.
Yeah.
Yeah.
And mental retardation. But the majority were the
majority
the
were the
34%?
schizophrenic and
Yeah.
the mood disorder, actually.
Okay.
Yeah.
These people are hospitalized at the same time?
Yes.
Okay.
Most of them.
Most of them.
Yeah.
Okay. Mm-hmm. That's interesting. Okay. That's very interesting.
And maybe, yeah.
Dr. German, please.
You mentioned that some of the other instruments used had limitations.
Mm-hmm.
And I'd like to know this new instrument that seems to be very interesting and relevant. What are the advantages now that you know that there's certain factors that are quite important?
Mm-hmm. So I would say the biggest advantage or benefit we could see was the difference, because usually we use questionnaires at the hospital, and so there we had many issues with patients not understanding or being very bored or upset about
language difficulty,
or cognitive difficulties, just to read the questions or to know how they should write between 1 and 10, how they feel. For some chronic psychiatric patients, it was very difficult, and having these pictures and these cards, first of all, it was more playful, so usually patients like this tool, and more easy. Much more easy for them.
Easier. And it's language free.
Yes.
So basically this is an instrument that can be used in every country.
Yes, so we have the words, I don't know if you saw, but we have the picture, and we always have the one word defining it, but it's very easy to translate. We translated it in French and English now.
It is already translated?
Yes.
Oh, wonderful. Thank you.
Psychological development. Did you speak?
Please, the microphone. We cannot hear you very well.
Disorders of psychological development.
Yes.
Did you mean pervasive development disorders by that?
Yes.
Like autism?
Yeah, exactly.
Okay. Just wanted to clear that.
Yes.
Thank you.
Yes. And maybe something I could add, because I didn't, is that our future research, we developed a new tool, which is this time assessing strengths of patients, because we also thought, okay, assessing difficulties and needs is interesting and good, but we also want to assess their strengths and their resources. And so now we are currently validating this new strengths assessment, which is also using cards and Q sorting. Yeah.
The card, it is very ingenious, very useful, and think it works very well. And who has thought about it, or it was a team of people that thought about the use of cards?
So it was a team of clinicians and working at the hospital and having always these problems with patients not wanting to fill out the questionnaires. And yeah, there it came out. But the Q-sort method already exists, I mean, but we really adapted this version.
Right. So it worked much better than filling questionnaires, etc.
For us at the hospital, yes. With this kind of patients, clearly, yeah.
Yeah, because it's handy, it's smaller, it's to the point.
Yeah.
It's very good, very excellent idea.
Thank you.
Any more questions? Any? Okay. Thank you very much. Thank you. It was very interesting.